Hello, my name is Chris Taylor. I'm a nurse practitioner at the University of Utah neurology team. I'm a member of the general neurology division and the autonomic division as well. And tonight, going to be talking to you about how POTS or if POTS are related to headaches and vice versa. Okay, so just briefly, objectives, we'll describe POTS, and then some of the most similar headache phenotypes that we see as a comorbidity with POTS. Discuss, are they related and how, and then treatment options, both for each, and then some that can be used jointly or to treat both the POTS and the headache side of things. All right, so POTS, or postural tachycardia syndrome, is, and a little bit of background, patients, at least initially diagnosed with POTS, are typically young, and I'd say the slide says between the ages of 15 and 50, and I would say, most common patient age or age range you see in clinic is about 15 to 30. There's certainly a it's more common in females than males, about 5 to 1 on average. And it affects a number of people in the United States. I think 1 to 3 million is a bit of a wide range, and that really means we're not incredibly sure, but I would side with the higher end of that spectrum, as it's still, I think, underdiagnosed in general. And then some common triggers for postural tachycardia be fluctuations in temperature, weather changes, certainly different foods, activity, especially exertional activity, dehydration, migraine and or other headache, sleep disturbances. And when there's fluctuations in mental health, when mental health itself isn't optimized. So the diagnostic criteria for POTS, so the gold standard is a autonomic reflex study, and we look at a number of different things during this, including sweat response to a small injection of acetylcholine, heart rate and blood pressure response to Valsalva and deep breathing maneuver, and then we look at those same vitals when we have patients on a tilt table. And we look at the comparison of both heart rate and blood pressure from when they're supine or flat to when they're tilted at 70 degrees. And to meet that diagnostic criteria, we look for a sustained increase in heart rate at 30 beats per minute above the baseline. So if someone's heart rate was at 70 when they were flat, and then it was consistently at 100 or higher when they are tilted, that would meet the diagnostic criteria. So in terms of treatment, as with many things, lifestyle is key and very important. Hydration with or without electrolyte supplementation is particularly important for patients with postural tachycardia. Sleep maintenance, if you're not getting good sleep, brain doesn't have time to rest and repair itself. And then exercise, exercise and avoiding deconditioning is very important. Equally important is for patients not to overexert themselves, or they can see an abrupt regression or decline in symptoms that often will take a few weeks, if not months, to recover from. And then mental health, as with anything, it can negatively affect our overall just state of health, but in particularly with POTS, when we have acute changes in stress or anxiety, and we have a brief uptick of norepinephrine or adrenaline in our system, it can really trigger and exacerbate symptoms of POTS. So optimizing that, working with your primary care neurologist to make sure that if you are having trouble, that it gets treated. And then compression garments, toe to abdomen, if possible or tolerated. And it's sometimes not tolerated by all if there's neuropathies or chronic pain syndromes that inhibit someone's ability to be able to tolerate wearing compression. Staying just with an abdominal binder or compression garment up to knee high is certainly better than nothing at all. There's an interesting study that was released at the beginning of 2020. The cohort was somewhat small, but it was still well done. They took a population of about 30 people previously diagnosed with POTS, took them off their medications they were being used to treat their symptoms with, and then put them back on the tilt table. And what they found was, and excuse me, to preface, some of these patients, they gave just knee high or thigh high, or all the way from toe to abdomen, a full compression. And then there was a group where they gave no compression at all. And those that had toe to abdominal compression in place when they were tilted, they had the least variation in heart rate and blood pressure and reported being the least symptomatic. So for a long time, we knew compression really helps with the orthostatic symptoms of POTS, but we were unsure, is more better. And although this was a small study, it certainly helped confirm some of our suspicions. So medication options to help treat POTS. So first of all, we want to treat the underlying tachycardia, or that's often provoked with position changes, especially after someone's been sitting for a long period of time and stand up. So our bread and butter, or gold standard of treatment to help treat the tachycardia are with beta blockers, so propranolol and metoprolol. There are other antihypertensive medications or medications used to treat heart failure, such as Corleone, that have also been shown to be helpful, but just used a little bit less frequently than the beta blockers. And to assist with vascular tone, or to help prevent any of the pre-syncope or syncopal episodes that patients with POTS experience, medications such as midodrine and mestinon can be helpful. And then if patients have trouble retaining the volume of fluid that they drink, if you're drinking 2 or 3 liters of water a day, but you feel like it's just going right back out, something like Florinef can be helpful. And on to headaches. So the 4 most common headache phenotypes that we see with as a comorbidity of postural tachycardia syndrome are tension type headaches, cervicogenic headaches, orthostatic headaches, or headaches that occur when someone goes from sitting to standing, and then migraine. So tension headaches, in terms of characteristics, they're more commonly bilateral or on both sides. Temporal or frontal are common locations to occur. In terms of the duration, lasting anywhere from 30 minutes to 1 week. The type of pain is described as more of a pressure or a tightening quality. Some patients will say they almost feel like they have a cap on and they're just being squeezed, or feel like their head is just in a vice and has just this constant pressure to it. And then it's not typically aggravated by routine physical activity, and we don't have some of the other, nausea, vomiting, light, sound sensitivity like we see with migraine. And then cervicogenic headaches, these are related either secondary to a cervical disorder, such as cervical myofascial pain. Those can occur when those tight little balls of cervical myofascial tissue get inflamed or irritated, and can feel, if you've ever feel like you have knots in your trapezius or your paraspinal muscles, that's what those are. And then these also can occur as secondary as if there's a lesion on the cervical spine on MRI. And they typically improve with the resolution of the underlying disorder. So with physical therapy, massage, heat, whatever it may be, if those that tightness or that cervical myofascial pain can be improved. These types of cervicogenic headaches often resolve. If they don't, and someone also experiences migraine headaches regularly, these cervicogenic headaches seem to be able to commonly trigger or make migraines a little bit more frequent. And then these headaches are also, and part of the diagnostic criteria is if they are completely abolished by a provider performing a nerve block, that also, one, helps treat patients' pain, and two, helps confirm the diagnosis. And then moving on to orthostatic headaches. So with postural tachycardia syndrome, we see blood pooling in our lower extremities, in our abdomen, and due to the autonomic dysfunction, our skeletal muscles and our vasculature aren't getting that appropriate signal, or getting a delayed signal that the nervous system muscles have to get the blood back up to our heart, lungs, and brain. So when someone stands up who has POTS, they can often describe, a relatively quick onset of a headache at the base of the skull, typically, or one that can develop over 15 minutes to even up to 2 hours of time of being up, walking around, or exercising. And then they often find significant relief, if not immediately, pretty shortly thereafter, of lying down or going into supine position. There are, or another classic headache type that can mimic this type of orthostatic headache is what occurs with intracranial hypotension due to a CSF leak. These headaches we see seem to be more instantaneous, or onset is much quicker upon standing. And then there certainly be other symptoms as well. Can have persistent rhinorrhea or cerebrospinal fluid that's leaking out of the nose that would certainly be more suggestive of that type of headache, opposed to an orthostatic headache as we see in POTS. And with the orthostatic headaches, they can often come in a coat hanger distribution, or you can think of from about the base of the skull down at the trapezius muscles and across, that it kind of looks like a coat hanger. And I think a good way to think of it is something similar that occurs when you get a Charlie horse or cramping in the middle of the night. There's brief reduction of blood flow to that muscle, or electrolyte disturbance that's causing that pain. And so similarly, when patients who have POTS stand up and there's not an absence, but a just brief reduction in getting that blood flow back to the brain, that a similar type of cramping or tightness occurs in the particularly the trapezius and the paraspinal muscles. And then on to migraine. Migraine, it's very, very commonly seen in patients who have POTS. Depending on the study you look at, there's reports of anywhere from 40 to 95% of patients who have POTS also experience migraine. Migraine in general affects about 12 to 15% of the general population. Again, women a little bit more common than men. They're often familial, and they share many of the same triggers that we see in patients who also have POTS. Heat, smells, sound, foods, weather, lights, whatever it may be. And if there's a single trigger that can trigger or bring on an abrupt onset of both migraine and POTS for a particular patient, you can imagine how debilitating that can be, dealing with this very bad headache, and then also the symptoms that come with POTS as well. So just briefly on the diagnostic criteria for migraines. So you see at least 5 attacks lasting anywhere from 4 to 72 hours. and then 2 out of the 4 of having a unilateral pulsatile or throbbing type of head pain that's severe in intensity and aggravated, not relieved by movement. And then at least one of the 2, nausea, vomiting, and or photo or phonophobia. Okay, and then and if this slide seems like a duplicate or all too familiar to you when we were talking about POTS treatment and lifestyle, you know, they are very similar. You know, dysregulation of any of these, you know, sleep, hydration, exercise, mental health, and although each patient, you know, has very unique triggers, all these are certainly possibilities. So acute treatment for migraine, there's a number of over-the-counter medications that can be helpful, you know, Tylenol, Excedrin, ibuprofen, naproxen, and if caught early, it can be helpful for patients who do have migraine, but it seems as, you know, more so just in the early stages. And in general, you know, when a migraine is severe, they get more challenging to treat. And then the most common subclass of medication options with migraine is likely triptans. Ergotamine and hydrogotamine are they're still used in practice, but less so. They have a part of its mechanism they have a significant vasoconstriction effect on some of the vasculature in the brain. So there are risks to using it, such as, you know, stroke or if other vascular diseases such as asthma, Raynaud's, things like that. And then some of the newer options are the CGRP antagonists, such as Nurtec, Ubrelvy, and then some the miscellaneous Midrin and Fioricet, which are a combination of a few different types of medications, with Fioricet having the least evidence and have a greater risk for rebound headache. And with prevention, again, over-the-counter considerations or nutraceutical considerations, particularly in patients who are pregnant or may not necessarily want to take a prescribed medication. Both magnesium and riboflavin are generally safe, and riboflavin in particular with an FDA category A reading for migraine prevention. And then for non-pregnant patients, feverfew and butterbur, also reasonable. Antihypertensives, so our beta blockers, calcium channel blockers, and others, antidepressant, anti-anxiety medications in terms of tricyclics and serotonin and norepinephrine reuptake inhibitors, anti-epileptic drugs, which are used to treat seizure disorders, and then the newest of the group, CGRP monoclonal antibodies. So CGRP is a calcitonin gene-related peptide, this little nasty protein in the migraine pain cascade, and these drugs work to either bind to that little peptide itself or block its receptor site so it can't attach. And then some miscellaneous memantine is a reasonable option, and or for treating other chronic pain syndromes. And then some of the newer non-invasive migraine treatments such as gamma-core, for instance, or some of the electronic devices that can be used. And then in terms of so kind of grouping all this together, looking at the pathophysiologic similarities with POTS and migraines, is that in both we see there's a dysregulation of the sympathetic nervous system that's occurring. We also see these hemodynamic changes in both, and then a degree of central sensitization. So future considerations, or things we need more research on, are possible pharmacologic options that may improve or be able to treat both, including the CGRPs I'd mentioned, Botox, and then a non-invasive vagal stimulator, or excuse me, vagal stimulator. Um, um, and although we know that lifestyle is absolutely key, and optimizing everything you can, sleep, exercise, mental health, hydration. Um, what we don't know is, are one of those the most important, or for either headache or POTS, or is there one that can be the greatest of help for both? And then also, I commonly see this in my patient population in clinic, but we need more research to be done. If one syndrome, whether migraine or POTS, if one of those improves, do we see any correlation or improvement of the other? And I'd say, in general, when my patients who I see primarily for POTS, if they're having a flare or an increase in their POTS symptoms, migraine is generally increased as well, in terms of particularly the frequency. So it would be important to know, both for providers but for patients as well, in that if you are experiencing an increase in POTS or headaches, to make sure and let your provider know, whether it's your primary care or your neurology provider, to ensure you're getting adequate treatment and relief. And so, for conclusion, I felt I had to put a somewhat humorous or funny picture up here to end this, as just both migraines and postural tachycardia syndrome, and just such a negative and debilitating effect on someone's life, that it's important to remember to smile and make sure you're taking some time for yourself and still enjoying life when you can. But just again, to briefly conclude, there are multiple different headache phenotypes that we see that coexist in patients who have postural tachycardia syndrome. And it's important to have the correct headache diagnosis, because the treatments differ depending on which it is. And then both orthostatic headache and migraine share some of the same kind of pathophysiology with POTS. And so, theoretically, if we can treat, one or the other and get one under better control, it's possible we would see improvement in the other syndrome. But again, we still need more research done there. And there's certainly overlapping medications that we use to help treat both symptoms. Propranolol in particular is commonly used both as a migraine preventative and to treat the tachycardia in patients who have POTS. And keeping in mind that medication, I would say in both, but particularly in POTS, is used to help get patients from point A to point B, so they start feeling a little bit better, and then can really work and hammer down on the lifestyle side of things. And importantly, keep in mind that with both headaches and POTS over the lifespan, it's very common to see fluctuations in symptoms, so both in terms of improvement and regression. So if and when that occurs, to not be surprised, and just to keep your provider posted, particularly if anything is new or different that you haven't experienced before. But it may just require a change in treatment plan, whether that's lifestyle and or pharmacotherapy. So that's all I had for my talk this evening. If there's anybody in the chat room, I'm happy to answer any questions, but if not, thanks for your time.